Good morning. Hopefully you've gotten your DevDays off to a good start. We're going to spend a few minutes here talking about connecting devices, device data sources using FHIR. My name is Todd Cooper, and I'm from San Diego, America's finest city. You'll know that if you go to the San Diego webpage and look at it, and guess what it'll tell you? America's finest city. All right, so when we talk about devices, there's all sorts of devices around. What exactly do we mean when in this session I'm talking about devices? Okay, first off, this is a typical ICU picture. It's really messy. There's all sorts of devices, some of which are connected, some are just totally islands of information. I have nothing else to say that other than not only is it visually messy, the information that comes from these devices is also equally messy, totally non-standard. From this acute care environment though, we call these point of care devices, or POCD. You'll see me use that numerous times. So there are quite a few different kinds of POCD devices here. Typically they're used in hospital or acute care contexts, and you'll see that they go from fairly simple devices, like a pulse oximeter that maybe only has a few parameters, to very complex devices. If you go out on the devices table, out in the test area, you'll see a physiologic monitor, which is used in this kind of context. It can generate hundreds of parameters at high frequency. So when you think about it, you have to be able to have a way of representing this information in FHIR that can scale from something that's a very simple device to something that's very, very complex, but using the same data elements to get there. So, like I said, these include physiologic monitors, ventilators, infusion pumps, pulse oximeters, these kinds of devices. Typically, these devices are used by clinicians or professional users. Okay, we'll look at the other kinds of devices in a minute. And everything I'm talking about today with regard to FHIR resources is built into the last release, STU3. So all of the tooling around that that you'll see is ready to support the device informatics pieces that we have here. The next kind of device is what we call personal health devices. And in here you'll see personal health devices might include a weighing scale. They might include a very simple pulse oximeter or a thermometer, something very simple. Typically, a personal health device only has a few parameters. So in general, they're very, very simple. They are also oftentimes connected to a personal health gateway. Think about this as a home context where you have these devices that connect within the home to a gateway, and then the gateway will communicate out to some other service, like a health and fitness service or a monitoring service. So when we're talking about FHIR, we're really talking about this part of the interface here. You have a data collection part that gets it within the gateway, and then you have this part that would use FHIR to communicate it out to the rest of the world. So again, PHDs, or personal health devices. Oftentimes these are home or mobile care contexts. They're relatively simple. Simple blood pressure, temperature, like I said. Even a simple urine analysis machine that you can use at home. Personal users, okay? So this is not necessarily clinicians or trained professionals. And then also, since the publication of STU3, there's a few different tweaks that we had to add in. So if you go to the current build of FHIR, you'll see the complete versions of the resources that are necessary for this. However, it won't be formalized until STU4. So if you're using tools, like I don't know if the Happy FHIR current version supports those few items here. It might have. They're catching up, I know. What about other devices? Here's an example. And we have, tomorrow we have a keynote from Google talking about Google Brain and this usage of FHIR and those devices. This is an example that comes out of San Diego, America's finest city, from Dexcom, continuous glucose measurement device company. who's partnered with Google. Google's looking to shrink this down to like a Band-Aid sized sensor that would then use a watch, a smartwatch, or a smartphone to pump this up to the cloud. Think about what you could do then. You have something very cheap, inexpensive that's able to communicate this information to the cloud, and then you can do all sorts of stuff with it. So when we look at devices, we have acute care, point of care devices, POCDs, personal health devices, and then we have this whole new generation of devices coming in. Wearables, Internet of Things, cloud-based technologies are bringing this together. It spans home to hospital care contexts. So it's no longer that device is used here and this one's there. You actually have these kinds of technologies that are getting used in all the different places. Typically, as you would see in this kind of example, yeah, the data stream is really simple, but there's a zillion of these that are coming onto the market. So if you've seen any IoT examples, for example, and wearables, you would see that the numbers are huge. And I know in San Diego, recently, Qualcomm partnered with another company for a vital signs patch. So very similar to this, that they're actually trialing in hospitals in San Diego. So when you go into the hospital, you're going to get that little patch. And it has an IoT interface to it, and now they're going to be able to do some very simple vital signs tracking from the second you walk in the hospital. So this is something that's very much there, and it spans personal and professional users. So it really mixes that space, like I was saying. So here's some additional considerations whenever you're talking about integrating device data. First is, who's actually using these devices? Is it a consumer kind of a device or a professional kind of device? These really do change, especially in terms of the numbers of these devices and the cost for these devices, and typically the simplicity and how they scale, as I said before. Another one is this regulated or not? This is an area that is on the move. A year ago, I would have said, yeah, we've got this nailed internationally. A medical device versus a health device, or a device versus health software. What's regulated, what's not? That's actually, as of recent European regulation, is now kind of changing. It's unclear exactly how some of these technologies would be regulated and classified. So when you're thinking about integrating device data, doing things like that, or doing software that actually has a lot of the capabilities that you might find in a device, this is a question you need to think about, because it's a whole lot harder if it becomes regulated or if it stays as health software. So this is just a consideration. We don't have time today to go into the details of that. I'd be happy to talk to you afterwards if you want, and especially at the devices table. And then also, as I said, health devices versus health software. So this is a moving target. So what's the big deal? Why do you really want to integrate device data? What is the value for integrating device data? Number one, as I said before, these represent islands of information. Oftentimes, hundreds of parameters on a very high frequency basis that don't go anywhere. They just stay in the device, which represents a lot of good information that could be utilized. Today, because the fact that almost every device uses a proprietary interface, being able to get that information out in a non-standard way and then normalizing it to a standard is expensive, is brittle. In other words, it's easy to change any one little thing and all of a sudden it'll break. And you have to redo the software. And it's complex. You know, when you go to point, it's pretty simple. But if you have to get from here to here, go here, 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 and then there, all of a sudden the complexities and the opportunity for things breaking increases extensively. That results in the fact that you have minimal content flow. Since it's such a pain, you're only going to get, even if you have a monitor that has 100 parameters or a ventilator, oftentimes a ventilator will have 200 plus parameters, you might only get 6 of them that are actually tracked and sent out to software to use. As a result, typically today, the most used application for device source data are flow sheets. That's where you would have a clinician looking at a few parameters over the last day or 2 days or week for a given patient. Very simple, And that's probably the primary use today of device-sourced information. You may have heard about the third wave of the internet. And FHIR-based device information really opens the door for the new apps that are identified by there. If you're not familiar with this, Steve Case, who was the CEO of a company in the US, Amazon or AOL.com, America Online, is one of the early pioneers in this space. He talks about the first wave, the first generation, which was just trying to get stuff connected. So in those days, when you bought a PC, then you had to buy a network card, then you had to get the right software drivers for that, for the operating system, and then you had to get the application, the software that worked with all that. It was a real pain. Today, whenever you get that stuff, you buy it, it networks straight out of the box. It's just a given that this will work. But the applications that they were able to do then were basic email or chat. AOL was one of the first to get a chat capability. You may have remembered You Have Mail came from AOL. The second wave was actually now doing interesting things that were baked into how we go about our lives. So you think about eBay, or you think about Amazon and doing online shopping. You think about Facebook and social networking. That was all the kind of good applications that were done during the second wave. But now we're solidly in or moving toward the third wave. That's characterized by seamless communication. Everything is massively integrated. Think about Internet of Things type of applications. The second one would be infinite processing power. So if you have information that goes to the cloud, now you can scale it. You can apply all sorts of processing power that you couldn't do before. So with that as a basis, what characterizes the kind of applications that we're doing in this third wave? Well, you have massive data. So big data, data analytics are key for that. A second area is artificial intelligence or machine learning or deep learning. And then the third one is personalization. Being able to take that information and then personalizing it for your experience. And when you think about healthcare, we see exactly those trends happening in new technologies within healthcare. We see analytics, both personalized as well as population health, being massively used. We see machine learning being used as part of this. For example, I heard a great application the other day where they would use machine learning to actually track, especially an elderly person, in their normal routines of the day, and then be able to use that to identify when are things outside of the normal to maybe indicate to a caregiver that something should be done or somebody should check on that individual. There's a zillion applications. Another area is gene sequencing and being able to actually look in real time for markers for a given individual around the genomic information. So there's those, and obviously precision medicine, personalizing this for you. So these are ways that it's being used. FHIR actually helps enable that in a few different ways. When you think about how device data is provided today, it's almost always streaming. So if a device is just sending this stuff out, typically to a gateway, the gateway is fire hosing all this information to whoever listens to it. And an EHR typically takes everything in and then triages it, processes it, and then uses some of it, and most of it ends up not being used. So what FHIR does is give you an on-demand access to that. You can query for things like, tell me what infusion pump has been used on this patient, or better yet, this infusion pump, which may have a calibration problem, for example. We discover that. We want to say, okay, well, over the last 6 months, what patients have been used for this on this infusion pump, vice versa. So you can do a query for a database very easily in FHIR to get at that kind of information. Clinical decision support systems are often based on wanting to query for certain kinds of information. So that's the difference. And then knowledge-driven, give me everything. So the HL7 version 2 type of processes that are used today, like I said, typically only support a small percentage of the information that's available from the device. But in a knowledge-driven, big data world, you want absolutely everything. So what we're doing in the Devices on FHIR initiative is we're actually mapping highly granular data so that you will be able to access that information in as much detail as you want. Doing kinds of applications that have not been really possible or thought about before this. And then finally, these are obviously some of the examples we've been talking about, decision support, machine learning, precision medicine, etc. This last point is interesting. Democratized access to granular device data is really what we're looking for. Today, getting access, especially to detailed device data, usually you have to go through 1 or 2 or 3 gatekeepers to get at that information. What we're looking to do is to use FHIR to be able to democratize that. So you actually can get it into a FHIR server, and now all sorts of applications can use this API to access that information at whatever level of detail is needed. This is a use case example. This is a demonstration we did. I'm going to show you a few examples of what I'm talking about. This was at HIMSS last year, clinical decision support example. In here, what we did is we had a physiologic monitor that had a blood pressure waveform that was feeding in a high performance event manager. What that event manager would do is detect for the pressure waveform, when is it outside of what might be normal, but it's not bad enough to trigger an alarm. So if you have a physiologic monitor, you're going to have alert settings, and whenever blood pressure goes up above or below a certain setting, it'll trigger an alarm. But there's all sorts of other variations that in and of themselves may not be significant. However, if you then correlate that with the medication administration record in EMAR, you'll realize in this example that a patient is actually having an abnormal blood pressure change within the same time that he's receiving this drug. He's not responding well to that drug. And so you have the events feeding this clinical decision support system along with this information, and you're running those rules, and you're able to identify this and be able to notify the clinician that Fred's not responding well to this drug and provide 2 or 3 alternatives. This system here also used a third-party sepsis system to be able to look and identify potential sepsis conditions. And they also had a genomic service that they used to be able to say that, oh, by the way, Fred has a marker that we know makes him not respond well to this medication. So this is what's interesting about this is whoever made these different services never had this use case in mind. But now we're able to put these together and do these interesting kind of applications. I have obviously here devices on FHIR and a question mark. Why is that? Because as I said a few minutes ago, most all of the device data coming out of the device is non-standard. And so what we're looking to do in devices on FHIR is the same kind of standards that are getting used in other places to normalize those APIs. We're trying to do exactly the same thing with the devices on FHIR project. This here is an example of deep learning. This is Asthma Brain. It's a new application that's being, or platform that's being put together that basically uses deep learning technology, pulls data from all sorts of different sources. As you can see, you have a person's activity, so just general activity kind of information, environmental information. What's the pollen count today like? What's the air pressure and the humidity, those kinds of factors, as well as treatment factors, as well as even community factors, and use this learning to identify how might we provide indicators to the clinician and to the individual to better manage their asthma. Think about doing this and now being able to add robust device-sourced information into that model. It provides much more accurate, better information. So consistent device semantics is probably one of the biggest problems here. So how do you get there to have consistent device semantics when all of these devices, as I said, are using different protocols? Today we have 5 standards-based pathways, if you will, for device interoperability. The first one, and the one that's being used the absolute most, is based on HL7 version 2.6 as a messaging transport, and it uses standardized semantics over that. Another one is the PCHA Alliance, or the Continua guidelines, which use an IEEE 11073 plug-and-play application service layer over Bluetooth, USB, BLE, Bluetooth Low Energy type of transport. This one here, the top one, the PCD, is typically for acute care devices, POCDs, whereas the second one is for personal health devices. We have some others, like in Germany, there's a European project, OR.net, that focused on interoperability within the OR. That's being standardized within IEEE 11073 as OpenSDC, and it's a SOAP-based technology. You have the medical device plug-and-play project that comes out of Partners Hospital in Boston, and that uses DDS. And then you have what we're doing in Devices on FHIR, which is using FHIR here. All of these have device content that go over these different technologies. They all use a different technology base, which depending on what you're trying to do, one may be more appropriate than the other. The key part here is that all of them use the same basic standards for the semantic content, the 11073 semantic standards. It includes the terminology that's specialized for health devices, for both POCD and PhD devices. What I mean by that is, let's say you have a device that conveys a piece of information, a given parameter, that's a very highly precise parameter for how that device actually did the measurement. Typically when we map that, for example, we have a few hundred of these that we've mapped to LOINC. Often it's a many-to-one type of mapping. We'll have 10 or more parameters that are unique from the device side that'll map to one LOINC parameter. And so it's really important to have specialized device-specific parameters. Also, this handles all the settings and configuration information that devices provide. So it's not just monitored values, but also all the settings and all the configuration information. And then a specialized model for device architectures. So even though you have these 5 standard-based ways of doing it, and literally thousands of proprietary ways of doing it, the good news is the semantics are consistent. So when we look at devices on FHIR, what do we want to do? We want to say, well, let's start with the same semantic base and let's map that so that's represented in FHIR well. That way, regardless of how that device data might be collected and the different kinds of devices it comes from, the FHIR API would be the same for looking at that information. So here is a highly simplified version of that 11073 medical device communication MDC model. MDC, by the way, is if you go to version 2 and you look at terminologies, MDC is a 3-letter acronym for this terminology. We have an object, a medical device system, or an MDS object, that represents the information about the overall device. For example, the configuration information of hardware, software configuration, the information about its unique identifiers, the battery information, things that have to do with the overall device, regardless of how simple or complex it is. We then have what we call virtual medical devices, or VMDs. Those are subsystems. So you might have a physio monitor that is very simple. It just basically has a temperature module and it has a blood pressure module. Maybe it has a pulse ox module, but those will be separate VMDs, subsystems, within this overall MDS. Sometimes those VMDs, by the way, are dynamic. So you might have seen some of these where you can actually plug in and out different modules. So even though the MDS will stay the same, you can have various ones of these that come and go. Way too much fun. And then each one of these has one or more channels. This is related parameter group information. The example I'm giving you here is if you have a 12-lead ECG, so you have these 12 leads, each lead has a little bundle of parameters associated with that. And so by taking this approach, they would all have the same parameter names for each one of these. However, because of how it's contained within a specific channel, channel 5 for example, within a given virtual medical device system on an MDS, you're able to understand the context of that parameter. And then finally, we have metrics. So this is the actual parameter. We have 2 objects for this. One is the metric object, which is an abstract object. It's metadata about general measurements. And then from that, we have one of 3 kinds of actual parameters. Obviously, numeric information, we have enumerations, and then we have waveforms. Okay, all of which have the same metadata base. And again, all of these are defined either in the 10201 standard from IEEE or the 20601 standard for personal health devices. So when we look at what do we do in FHIR, we actually are mapping from this simplified model to a very small set of resources. So at the MDS level, actually the MDS, VMD, and channel level, we all use the device component resource. We're profiling those right now though, so we'll have an MDS profile, a VMD, and a channel profile for each one of those. That's in the implementation guide that we're working on right now. We then also have a device metric resource that has that data, the abstract data, and then we map various of the fields here to an observation. Okay? So we have very simple, clear mappings, and an observation obviously is going to relate to here because you know the context in which that value exists, and they all reference back to a device. And then obviously observation and device both can reference the patient. So looking at this, you can see how you'd be able to go at this and say, for a given device with specific configuration information, what patients has that been used on for the last year? So there's a lot of different kind of searches like this that will happen. Which if you just had the patient and the observation information and not this detailed device information, you'd be hard pressed to get at that. For personal health devices, as I said, they're a lot simpler. And so here you have a single instance of a device component. They just have an MDS object, and then they map their numerics, enumerations, and waveforms into fields within the observation. Those objects on the left, they have actually fewer data fields, so it's much simpler. And then obviously the relationship to the patient. But again, we're using the same simple semantics. So let me just talk for a moment about the Devices on FHIR initiative. We started this last year in the summer of 2016 as a joint effort between HL7 and FHIR, IHE USA here, and IHE International, as well as the Personal Connected Health Alliance, which is what now is continuous, part of this HIMSS organization. So in other words, the organizations that are primarily working on integrating and standardizing device data, we're all working together in the Devices on FHIR initiative to get a consistent set of FHIR resources that can be used to communicate this information. We have weekly meetings on Wednesdays at 6 o'clock in the morning, San Diego time, which is a very nice 1500 here in Amsterdam. We're at all the FHIR Connect-a-thons. In January, we'll be have a Devices on FHIR plug-a-thon as part of the North America IHE Connect-a-thon. Last year we did that in the US as well as in Korea last August. And then we're working on jointly developing and testing profiles and implementation guides. So it's a very busy group. Let me talk to you for a second about Holly and Danny's story. This is a personal use case here that I experienced last December. What's interesting about it is it crosses numerous different care contexts. And at the table today, where we're having the devices table over there, we actually have a physio monitor and we have personal health devices and exercises around this story. So you're actually able to work through using those resources around this kind of context. So the way the story goes is Holly was monitored for preeclampsia, that's hypertension, during pregnancy. And then what happened was Danny decided to come a month earlier via emergency C-section. And as a result, when Holly was sent home, typically when a mother is discharged after delivery, her blood pressure returns to normal. The preeclampsia goes away and life goes well. In this case, it didn't. It actually spiked at over 180. And she was readmitted, I think, 2 or 3 different times, along with Danny, her newborn child. And it took them quite a few times before they were able to figure out the right kind of therapy. And the good news is, or as I said, so this is both hospital and home care context and both kinds of devices. So they're monitoring similar kinds of information when she's in both places. However, depending on the kind of device, typically that would have required different types of standards and adapters. However, in this case, they were able to use the FHIR API to have a consistent one. I'm happy to say both Holly and Danny, the little guy, are doing very fine today, but it took quite a while. This is then a similar example to the last one, only on the PhD side, we started with, or on the point of care hospital side, we started with patient blood pressure device going into the CDSS system, which was able to do the same kind of detection, but in a hospital standpoint. In this case, we actually did this demo earlier this year using FHIR as a way of doing harmonized semantics. And then what we did is when we sent Holly home, we gave her a pill box, a pill minder box, that every time she would take her medication, it would actually generate a message to her iPhone or Android phone, which would then use FHIR to pop that up to the cloud. Going through the cloud service, that would go to the exact same clinical decision support system, looking exactly the same. It had been normalized using FHIR, and then that could generate the rules to notify Holly or her clinician about changes. And that CDSS engine could watch as she approved or didn't. So connecting devices, as I said, we have a hands-on track. We'd love for you to come by, some exercises, and it'll go both looking at device data sources, either consumers, applications especially that want to use that. Around this P3E case, we have handouts that we can give you for that information. And we also want to point out some of the facilitators. So Melanie Young is here, and you'll be able to see her at the table, as well as Stefan's not here. No, Stefan, you're there. Stefan will be there, and then I think John Rose, who you don't see here, he'll be also there. So there'll be three of us, at least one or two of us will be at the table at all times to answer your questions and to take you through this. And so what happens after this going on? What are we doing in the Devices on FHIR initiative? First, tomorrow morning at 9:45, Melanie will be giving you a Continua personal health device focused overview. So don't miss that. And then right now, what we're working on doing is finalizing the implementation guide for personal health devices and point-of-care devices. And you should expect to see those in the December ballot. So look for those, and if you want to become involved in that, we'd love to have you contribute to putting those together. And then, as I said, we have weekly meetings. We have a listserv that you can tie into. We have connectathons, tracks. We'll be in New Orleans in January, so feel free to, there's a lot of ways to engage, and we look forward to having everybody participate in that. And that's it for today. Hopefully you got a little taste of that. When Melanie presents this tomorrow, she'll show you more detail around the specific FHIR data structures, for example, that we use for this. Thank you very much. And thank you.
You didn't really talk about, what about lab devices?
So lab devices and imaging devices are outside the scope of what the Devices on FHIR piece is looking at.
Okay.
That said, the preeclampsia use case looks at lab values, right? So you're looking at protein,
Right.
what is it, proteinuria? Or, in fact, Melanie, who you'll be able to see at the table, she just gave birth earlier this year, and that's how they found out that she had preeclampsia. And so they were able to, I'm all done. So that's how they were able to find out that she had it. And then my wife did the same thing for our youngest child. You end up on bed rest for a month or two. And so the last few weeks of her pregnancy. So what we're doing is we're expanding that use case. And we're targeting the January Connectathon in Cleveland and probably the FHIR Connectathon late that month in New Orleans to include both the lab readings as well as the pills as well as the blood pressure readings in hospital, in home, in clinic with the obstetrician. So trying to put all those different care contexts together as a way of both validating that we actually got the FHIR spec right and being able to show the power of having a consistent way of accessing this device data.
So will those lab results, though, are they coming from the database that they're recorded in, or are they actually coming directly off the instrument?
Those would typically come from a database.
Okay.
Yeah.
So will they? So
there is. Let me just say this. There is. If you look at orders and observations,
right.
They have lab-focused FHIR specifications they're working on.
Right.
If you look at the PCH Alliance continuous stuff, there's one of those IEEE 11073-104-72 or something, which is a home lab, urinalysis device.
Okay.
And the intent is to have exactly the same FHIR API, so I really don't care what that source was of that information, but I'm able to access it. The content's the same. What I didn't say is, like that CDS engine, for the demo, what was interesting is they used the two different kinds of devices, and especially the location, to tweak the rules. Because typically, if you think about it, in a hospital, it's getting calibrated regularly. It's actually blood pressures taken by a professional, so there's a whole level of quality there that at home you don't have. So it may not be, who knows when it was last calibrated, even if you were sent home with it and it was good then, a month later, and you may not have gotten the cuff on right or something like that. So they actually use that to tweak the tolerances, so that whenever you're home and they're looking at this data stream coming through the cloud, they're able to better, they basically have looser tolerances on that. So there's a lot of things you can do. But the problem to date has been getting your hands on the stinking data. And in any sort of volume. And so if we're successful with this, what we'll be able to do is have that FHIR API and have centralized repositories that can provide a very simple way of integrating that. Okay?
Can you talk a little bit about how you store the device readings? So for example, like if you have a heart rate monitor that generates reading every second or every 5 seconds, what FHIR resource would you use to store that information? Is it the observation, but then you probably don't want to create multiple observations per reading? So what kind of structure?
So right now we haven't even, typically that's not something that I think we do within the FHIR context. We're looking at how you access that information, how you exchange it, but not the database. How you implement it behind that wall is different. Here's a key reason. If you're talking about device source data like heart readings, it is it's all medical data, but it's really important to ensure the reliability of that data. And so the manufacturers that have device data repositories for clinical context jump through a lot of hoops to guarantee that the information that was received, stored, retrieved is exactly the same, that it hasn't been corrupted. And so there's all sorts of technologies that you might have to use behind in the infrastructure. And depending on how that data, did you get it straight from a gateway that's like in the next room, or did it go through the cloud from a home? Those kinds of, all sorts of different infrastructures. But I think at the end of the day, what we're saying is if you use this FHIR API, you have a way of building an application to pull that in to be able to then use it, regardless of how it's been collected and persisted. And I think that's similar to what you heard in the Google Brain discussion. It's like, yeah, there's all this stuff going on, but we were trying to do this, and we didn't want to get sucked into mucking with all of those kinds of details. And FHIR gave them an easy way of building, firewalling, if you will, that stuff.
But I mean, isn't part of having the FHIR on device so that the device can upload data to FHIR server directly? Or that's not part of the...
It may or may not be the part.
Okay.
It could be that you're using, so here's the other part. And this is why in 30 or 40 minutes I didn't go into this kind of detail. This gets back to the regulated question. And so most device manufacturers today that have network devices have regulated networks to collect that information. Proprietary. So one of the drivers behind proprietary stuff is that I have a gateway, but from that gateway back to the actual devices is something that I've validated and gotten approved by regulatory authorities. Whereas now from the gateway to whoever in the enterprise, cross enterprise, that's a whole different question. And that's an area that regulators have tried to stay away from. But when you're talking about in an ICU, for example, collecting real-time physio-monitor data, that's all uses this proprietary technology, many times because of the regulatory requirements on there. Now the Open SDC protocol, that's absolutely SOAP-based, but it's absolutely what it's designed to do. The 11073 protocol for point-of-care devices has actually been deployed by Philips globally for decades. And so it's, that core technology represents that. But typically that's why we have formats. For example, if you look at those base standards, it has formats for waveforms. We're still discussing in FHIR how to best represent that waveform. We've done it in CDA, so like if you do drug study submissions to the FDA, we have a CDA-based representation standardized on these standards. We do it in version 2. We have a way of doing the IHE PCD wave snippets and things. So if I have an alarm and it's a systole and I want to give you a little wave snippet so you can look at that, yeah, that's all defined. But again, the infrastructure that's behind that has all sorts of different design drivers and regulatory drivers. Okay? All right. Thanks for hanging in there. Thank you, Michael, for using your computer.
So